Good afternoon, ladies and gentlemen. It's a great pleasure being here. Thank you for your energy, for your work for patient safety. I salute you for this. I also would like to say thank you to Joe and President Clinton and Jim with a great interest and for their work. What I'm going to do today is I would like to introduce you to a patient safety project and will guide you through the results of 130,000 patients which we just have finished the trial. Anemia, as you can see at the top, it's occurring in this country, in any country, and has a high mortality risk. Blood loss and bleeding, the same. Transfusion, the same. But if you have all three together, anemia, blood loss, bleeding, and transfusion, then the whole thing gets even worse. So there is a fantastic study covering over 200,000 patients undergoing elective surgery. And what they have found out is the following. As you can see on the right side, if you have no anemia and you're being operated, any operation you can think about, is only cardiac surgery has been excluded, your risk to die within 30 days is less than 1%. But if you have anemia, only mild anemia, which is defined as a hemoglobin between 9 and 12, that's the middle bar, your mortality rate increases by the factor of 5. So I'm asking you, are doctors telling their patients? No, they don't. And if you have a severe anemia, hemoglobin less than 9, this increases by the factor of 13. So imagine a loved one, a relative, son, brother, sister, wife is being operated with anemia, which is very, very present. And suddenly, for a normal operation, mortality increases by a factor of 13. You wouldn't allow this. So we have to make people aware of this. So, a worse postoperative outcome anemia, we have further infectious complications, hospitalization increases, and morbidity and mortality. So, men are all the same, like me, we like fast cars. So, if the men now, women as well. So, just close your eyes and imagine you get a present. One day in Dubai maybe, and you get a really fast car and you can drive around the whole day. Would you like to start your car with this tank? No. You would like to run your race with this tank. This is exactly what we need to do with patients who have anemia. We have to put them into the race, but sort it out their problem first. So, preoperative anemia. And you have to see the data at the top. In men, we have, the WHO has defined anemia with a hemoglobin less than 13, in women less than 12. And if you look at preoperative anemia, there are a lot of reasons. But the main reason, you can see on the left side, sorry, it has been changed now, it's in the middle, iron deficiency. Can you imagine that we have in this country 40 to 50% of the patients have iron deficiency? Can you imagine this? It's true. What does it mean? It means it can be treated very fast and very effective. But if we don't treat it, then we have a problem. There are other forms of anemia I don't want to go through. Even the WHO has now taken the project, patient blood management, on their agenda, and it urges member states to implement patient blood management. There are various concepts spread over the world. You can see in the United States, they've started a program, the United Kingdom, Australia, and also Germany. And I would like to introduce you the German PBM network. So, in the world, there are approximately 324 million surgeries. 70 million of these patients have preoperative anemia. 70 million. And if you calculate now the mortality rate, 30-day mortality rate, 2 to 7 million patients have the risk to die. So by sorting out their anemia before surgery, we can prevent deaths every year, 2 to 7 million. If you talk to surgeons, anesthetists, intensivists, and you ask them, have you anesthetized, have you operated on a patient with a hemoglobin less than 12, 10, 9, 8, and it was elective? Always arms go up and said, yes, I've done this, because they haven't been educated. That is really dangerous. So we have started a clinical project, patient blood management, to increase patient safety. And we have done this with the Department of Transfusion Medicine and my Department of Anesthesia, Intensive Care Medicine and Pain Therapy. And this project has its foundation on 3 pillars. It's management of preoperative anemia, minimizing blood loss and bleeding, and restrictive use of blood units. Let me quickly guide you through. What we have implemented in the hospital is an anemia walking-in clinic, because a third of our patients have anemia. So it is really a common disease. And we usually say in medicine it's a symptom, but we say now it's a disease. And a disease needs to be diagnosed and needs to be treated. So we have this walking-in clinic with really, really talented young people who love to sort patients out and to give them a better start in their surgery. We also had to realize that we have to educate our colleagues, because before, when patients had to undergo surgery, it was not relevant whether they had anemia or not. So we had a hemoglobin value, but we didn't make anything out of it. People have been operated on. Now it has changed. Together with our surgeons, we have implemented this cartoon where we first say every patient who doesn't need urgent surgery, so within 4 days, is classified as elective. And if a patient is elective, then we have to make sure the patient starts with the right hemoglobin. And if there's a risk of transfusion, this needs to be taken serious. And you can see down here, if anemia is present and there's a risk of transfusion, then we have to go further in diagnosing this patient. So overall, it is important to give the patients the right start. So imagine what a hospital is. A hospital is a place where sick people are going, and a lot of them have anemia, but there's also anemia made in hospital. The elderly lady, I'm a positive person, comes with a half-full glass of red wine. Obviously, it's her blood. And then we're coming into the whole game, the doctors, we're taking even more blood. And we make the patient even worse. And I'll give you some examples in a minute, because the second pillar is minimizing blood loss and bleeding. And there's a lot of techniques we can use in a hospital exactly to achieve this goal. So that's my question to you now. How much blood are physicians taking in one patient per week for diagnostics? Who is for 50 ml? No hands. 200 ml? 400 ml? 600 ml? 800? Yes. I will give you an example. And it's not only an example, we have measured it. So the situation, young man has 6 liters of blood volume, and the elderly lady, she's already a little bit weak, and she has 2.8 liters of blood volume. They both have been admitted to intensive care. That's a true story. The minute they hit the bed, they've been treated the same. So we're just doing a standard, and we take our blood results. And we have calculated this. And you see, day 1, 2, 3, 4, 5, 6, 7. And the first day, we're taking twice laboratory data, 3 blood cultures, and we take blood gas analysis, and obviously cross-match. That's already 188 milliliters of blood. After 1 week, we have taken 634 ml of blood. The young man started with a hemoglobin of 15, which is normal. After this week in hospital, hospital-made acquired anemia, his hemoglobin is 13.4. That is almost anemia by the WHO definition. The lady, she started with 11, and after taking blood, it was 8.5. And most physicians already would think, oh, 8.5, she's old, she might have cardiovascular disease, I might have to transfuse her. If the story goes further, you can see, unfortunately, both patients developed septic shock. And they had also cardiac and pulmonary and kidney dysfunction. Both ended on the renal replacement therapy and an ECMO. And now you can see what happened. We had to take more blood. We had to do more tests. We had to do a lot of problems. And you can see in 1 week we have taken 1.6 liters of blood. And that is true. No one is talking about this. So the young man, a hemoglobin of 15 down to 10. The lady, 4.8. And she definitely needs transfusion. So that tells you that a thing, what we all think is normal, taking blood and being tested, it's in my eyes, it's not normal. We have to be very, very precise. Is it really necessary to take blood? And if yes, what needs to be done with it? And also, there must be a consequence on the data which have been obtained. So, the word is hospital-acquired anemia. Do you have any idea how much blood has been taken if you're 90 days in hospital? What do you think? One patient, 90 days. There's a lot of patients who have, unfortunately, spent 90 days, 9-0, in the hospital. Any idea? I'll show you. 5 liters. 5 liters. That means the blood volume has been changed completely. So it's a new blood in the patient. And there, believe me, patients who are even longer in hospital. So, what is our mission? What is, hopefully, your mission? At the moment, we are the vampires, you can see on the left side, but we would like to be little mosquitoes. And if you talk to pediatricians, they're the best. And I'll give you an example. Clinical laboratory is calling on the phone, yes, you have taken blood from this patient, X, Y, is not enough. What is your reaction? You go to the patient, take another sample, send it to the laboratory. That's the way we do it. If you do the same with a pediatrician, the pediatrician is saying, no way, man, you have to deal with what we have given you. And that's the difference. And we have to have a change in our thinking and how we deal with patients. So there are a lot of things which can be done. And you see in the middle, this little syringe and the plastic. We had an experience when, for example, patients on the intensive care or intermediate care, they all have lines in, arterial lines, central lines. And you know what happens? So the patient, someone needs to take blood for a blood gas analysis or whatever. So the nurse goes to the cupboard, takes the plastic out, opens up, there's a syringe, goes to the patient, connected, takes some blood. And then, because the blood is not pure blood, there's a cell line in whatsoever, she goes to the bin and throws it away. Then she takes a real sample, and then it's been sent to the laboratory. And we calculated this. This is an unbelievable amount of blood. So now we have a reflush system. It's very simple. There are meanwhile 4 or 5 companies on the market. So this reflush system, you take patient blood and the cell line, whatever, in a reservoir. Then you take a real sample, and then you flush it back to the patient. Imagine a patient on the intensive care unit, sometimes 10, 15 times a day, blood has been taken. You can imagine how much blood this means for the patient. And these are the patients who are really sick. So that is really an advancement. And if you think this is expensive, no, it's not expensive. Because it could be always an argument, no, we can't do this, it costs too much money. It's not true, because if you calculate everything, the syringe you have to take out, plastic, take the sample, throw it away, take the next one. This reflush system is even more cheaper. So it really makes sense to introduce this. And the other thing is, why not using less blood? So we discussed this in the hospital, talked to a laboratory and said, is it possible that you with half of the volume do the same test, the same quality, everything the same. I said, okay, let's try. We did it, everything. They said, oh, it's working actually. So we talked to all clinical directors. Are you happy that we are using smaller amount of blood? No one was against it. Then we had this company who was actually producing these tubes. They were very happy because it's a boring company. First time in their life, they're increasing patient safety because smaller volume. What else can be done? You need to have a plan. In a hospital, you need to have standard operating procedures. That's exactly what we do. If a patient is bleeding, you need to have a plan. If it's surgical bleeding, you can do whatever you want. You can put lots of plasma, coagulation factors in. It won't stop. You need a good relationship with your surgeon. The surgeon has to do the job and get this bleeding sorted out. If this has been done, then it's our job. Is the patient not too cold? Is the temperature right? Is there the pH? Okay, so we have to look at physiology. We need to know which drugs has the patient taken. And also think about lots of other things, so it's a pyramid of action. And this is important just for younger doctors to know there's a plan. And this plan needs to be followed through. Let me come to the last point, restrictive use of blood units. Monitoring the tolerance of anemia, restrictive transfusion triggers. This is a really interesting trial. 16 hospitals in Austria. They all did the same procedure. They did hip replacement or knee replacement. The patient population was exactly the same. And what you see is yes, no, maybe. And if you look here, if you're in hospital number 10, the risk to be transfused for hip or knee replacement is 90%. If you go to hospital 15, 12, or 13, it's less than 20%. Which hospital would you choose? 10 and 8, or rather 15, 12, or 13? It's obvious. But are you aware of this? Do you have the data? No, you don't. As a patient, you need to know how good or how bad hospitals are performing. So we believe there's a huge saving potential. There's a lot of international guidelines telling doctors what is the sort of right hemoglobin. And we have, in Frankfurt, in Germany, we have the guidelines of the Medical Association, and we translated this on one page for the hospital. And also we kicked away the paperwork and said every doctor who would like to transfuse a patient needs to go on the hospital computer system, identify themselves, and then make a tick on the box. What is the reason for transfusion? This alone reduced the amount of transfusion and also ordering by 20%. That's all, 20%. No patient got harmed. So there's a lot of things need to be done, and we have to really, really talk about guidelines and making sure that doctors are following them. We need checklists. And checklists, I'm a huge fan of it because if there's a stressful situation, people need to be calm. And they only can be calm if they know what to do. So we need preoperative, intraoperative, and postoperative checklists. It's very, very simple, but it needs to be done. The most difficult thing for patient blood management, ladies and gentlemen, is you have so many disciplines, so many people interfering. There should be all partners, but you need to get them all on board. We never should forget the most important thing is the patient. But there's pharmacy, there's surgery, there's hundreds of different important people in this whole game. If this all works together finally, then we can increase patient safety. So, how does it work? So sort of change management. You need to get people infected with the idea. Patient blood management, it's on my shirt, it's on my tie, it's on my phone, it's everywhere. And you have to just make them aware of, what is this? Oh, wow, that sounds interesting. What does it do? What can I do with it? You increase patient safety. Ladies and gentlemen, this is also a way, it's not me. I wish it would be, but it's one of my consultants, and this was the most used screensaver on the intensive care unit for a year and a half. The guy is married now to a lady from Ian Olsen's Road. I wouldn't be here for the commitment of Joe, and I allowed myself to give him the Bavarian hat with the patient blood management logo, because I believe he believes in what we are doing. And I would like you to introduce now to the trial. And before I do this, I would like to invite to stand up the representatives from Kiel, Frankfurt, Münster, and Bonn. They all were traveling with us. Thank you. 4 university hospitals. And what we have done is very simple. You see 4 centers, and we started to get all the hospital data before the implementation of patient blood management. Then we had an implementation period of 3 months where we did heavily education, training, teaching. In Frankfurt alone, we were almost teaching 800 people in the 3 months, nurses, doctors, and so on. And then we started with the implementation of patient blood management. And you see, altogether, almost 130,000 patients. Ladies and gentlemen, my commitment today is to show you the first data no one has seen before. We haven't published it so far, but I believe it is important for this environment, for you, to get the idea and also some of the data. Before transfusion, what do you think? How much transfusion has been reduced in 4 university hospitals? By 17%. Complications. There was no issues. Overall, patient blood management is safe. What we have observed, and this is really alarming, a 40% reduction of acute kidney injury in the patient blood management group. Are you aware of acute kidney injury, what that means? I'll show you one picture. If a patient in a hospital is suffering from acute kidney injury, at the beginning you see nothing. The patient will be on renal replacement therapy, and that's it, and the kidney is working again, all fine. But if you look now, after 5 or 10 years, there's a huge difference. After 10 years, the group who had acute kidney injury, they have a 20% higher mortality rate. 20%. And that is so tricky because we give a transfusion, everything is fine, patient is okay, being discharged from hospital, and several years later, the problems start. So we have a very good reason now with our data. If we reduce acute kidney injury, we will prevent death. What else? I showed you this. Money. Money talks. And we have also a 20% reduction in the cost. So after the implementation of patient blood management, we saved the system 20%. That's a huge amount of money, which in my eyes should be invested in patient safety. So this is the data I would like to show you. And now I have only some more ideas. We were developing 100 bundles, which in our eyes should be implemented in every single hospital. And believe me, you can't work with 100 bundles. That would be the ideal world. But we believe if you have 20 to 30 PBM bundles implemented in your hospital, you increase patient safety, you reduce deaths. And like everything in life, there must be award. People like to have awards and certificates. And you can see our idea is now that if hospitals implement their bundles and they're good with the bundles, they should get awards. And that goes up to diamond and platinum. And we believe this is a way to motivate the hospitals and doctors to be part of it. We also realized that doing medical studies, all doctors are not being prepared for the future. Well, once they have the license, they have the license also to transfuse. But they don't know what transfusion means, and they don't know the risk of transfusion. So we decided we have to provide an e-platform for doctors that they know what they're doing, the Patient Blood Manager platform. At the moment it's in German. It will be translated into English as well. And at the moment, every single doctor in my department, there are over 100 doctors, it's mandatory for them before they're allowed to touch blood to do this course. This is increasing the knowledge and patient safety. And it has different modules, as you can see. So coming back to the point, if you put everything together, what I told you, so many surgeries per year, 324 million, 70 million preoperative anemia, 2 to 7 million preventable deaths, plus 40% less acute kidney injury, then I can tell you we're talking about millions of lives we can save together. And this is not rocket science. This is not rocket science. It's the only thing, discipline, and telling doctors in a hospital as a team all together what to do. Ladies and gentlemen, thank you for your attention.